Welcome to the Pot of Inquiry. My guest this week is Dr. Michael King. Mike is a good friend of mine and a very respected colleague throughout our profession. Mike is the Chief Medical Officer of Upperline Health and has a vast experience in billing and coding and lectures nationally on these subjects. He's going to talk to us today about the changes that are going to come in 2030 with Medicare, going from a fee-for-service to a different type of reimbursement structure. I think you'll enjoy this conversation that I have with Dr. Michael King. Stay curious.
Welcome to the Pot of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome, everybody, to the Pot of Inquiry. I have a good friend and colleague, Dr. Michael King, on with me today. Mike, thanks so much for taking the time to come on the show.
Thanks, Steve. It's always a pleasure to see old friends and talk about stuff that you and I have bantered about for years together.
Right.
It's very exciting.
So before you get into the weeds with what we want to talk about, some of the changes in Medicare, why don't you tell people what you're doing now? Because I think what you're doing with Upperline is very interesting.
Yeah, so it's actually really cool, Steve, because I was in private practice, not unlike you, for over 30 years. I had a limb salvage practice in New England for 30 years. Struggled like we all do in the podiatric medicine and surgery world with being sort of the redheaded stepchild of getting, people understanding what we really do. And anyway, what happened is you and I were actually working together in Atlanta at the time, and
Right.
Upperline came along, and it was interesting. Our CEO, David Thorpe, had this vision that I've never heard from anybody else outside of our profession of where healthcare was going.
Okay.
And that's what we'll talk about a little bit later, is that it is evolving, and if it doesn't evolve, it's going to collapse. It's just not sustainable. And so his vision, which was incredibly insightful, in my opinion, was that we in podiatric medicine and surgery have the ability to change the paradigm of how healthcare is delivered. It's because I think you and I have talked about the fact that it's been a reimbursement-based system, not an evidence-based medicine type system.
Right.
And, we all survive on those reimbursements, and that's what that's our job. We get paid. But again, it's not so sustainable. So anyway, David was part of a end-of-life company, a hospice company, and the payers talked to him about the real problem with wound care and amputations in particular at the end of life. And it was very costly and devastating socially, physically, mentally, all you name it for these people.
Right.
And it's like, how do we solve that problem? And what he realized was that it was really lower extremity care, podiatric physicians that had the ability to change that paradigm. So he started Upperline. I was employee number 3. We now have 383 providers.
Wow.
Across 19 states. And we are a fee-for-service company still primarily, but we also have the first and only specialty-based ACO in the country. So ACOs are accountable care organizations. Many of them have bad reputations because they failed because hospitals ran them into the ground because they can't get their head out of the fee-for-service world. And providers weren't always treated well, nor were patients. So we have this program, part of what's called ACO Reach. It came out during the last Trump administration, and the inventor, Adam Bowler, who's a member of our board, came up with this concept of value-based healthcare.
Okay.
And so what it really is using protocols, evidence-based types of treatment, things that you and I know, simple stuff, simple as offloading a diabetic patient before they get an ulcer.
Right.
Getting them into shoes, getting a vascular evaluation, getting a neurological assessment,
Right.
dealing with the problems before they become crises and lead to amputations and extremely high admission rates, et cetera. So what we're doing at Upperline now is we have this ACO. We've got between 30 and 50,000 Medicare lives in our ACO right now
Okay.
that we are essentially their insurance company. So we manage them from stem to stern. We are a full risk company. So whatever happens to them, we take care of.
Okay. Now, do they contract with you from a different, how do they get plugged into that?
So they get plugged in. And here's the cool part, Stephen, is that they get plugged in through our offices. So
Okay.
you see for example, in your nerve world, you see those neuropathic, devastating, chronic pain aside, you see those people who are at a risk for a Charcot or already have a Charcot or they have
Right.
neuropathy that no one's paid attention to. And you walk in the room and you know right away. You ask them two sentences,
Exactly.
So they're already part of our clinics. One of the things that we discovered and have certainly proven now, I think it's greater than 70% of the patients don't even see their PCP within a 12-month period of time.
How much was that? 70%?
Yes, massive numbers of people
Wow.
do
Yeah.
not even see a PCP in a year. It might be 14 months, it's longer. They see us 4 to 6 times a year, podiatrists.
Right.
So just that frequency of visit, and this is interesting, Steve, because it's so contradictory because I think most payers look at the less time people are seen, the less money it costs them, right?
Right.
What this system shows is that the more time somebody is seen, the less it costs them because
Right.
you're preventing problems.
Exactly. Exactly.
And so that's what this is really about. It isn't just about frequency. It isn't just about frequency, but the more often you see someone, the more likely you're to find a problem before it goes downstream and leads to a more serious problem, right?
Right.
So that was David's mentality 8 years ago,
Right.
and now we've proven that that actually is effective. I mean, I can tell you that the medical loss ratios in our company are well below 90%. That's almost unheard of. And that means that we're saving the system theoretically 10 to 15% of the expenditures simply by seeing these patients on a regular basis and becoming engaged in their health care.
So let me interrupt you because I think that, this is something that people and patients don't have an idea on. Their insurance premiums are going up every year. They've never gone down in the last 30 years that I am aware of. And the amount of money that they're paying us today is a fraction of what it was 20 years ago or 30 years ago. So they're getting charged more and essentially they're getting less. Where's all that money going?
Well, I'm not an actuarial, but my opinion is it's being wasted. And I mean, hospital expenditures are massive, number
Right.
one.
Right.
Facility expenditures are massive.
Right.
They're a necessary evil, so to speak, to some extent, but there's a lot that can be saved. I mean, if you look at it, I'm not shilling for Medicare here, but CMS has about a 3 to 6% administrative rate, if I remember my numbers correctly. If you look at a private insurer, it's 30 or 40%.
Right.
So there's your money, right?
Right.
And so like to your point, your premium that used to be $150 a month, now you're spending $1,500 a month
Right.
for less coverage.
Right. And monstrous deductibles.
Oh, excuse me. Yes, massive. And
Yeah.
if so, we need to get ahead of this. And you and I have talked about this a lot, is that doing things that have proof. And as you also know very well, getting the people in the payment world even to understand that.
Right. Right. Well,
and
I mean, here's a great example, right? And it's not even in this instance that I want to put out as an example. It's a covered service, but let's talk about peripheral nerve decompression to reduce the incidence of recurrent ulceration. I mean, the studies are out there. I mean, Scott Nickerson and Sonny Yamasaki just published a great paper in the Guidelines Journal, Wound Care Guidelines Journal, where they they've shown that the recurrence rate, which is normally 40% annual recurrence, can be with peripheral nerve decompression surgery, which doesn't cost that much money, it brings it down to below 2%. Now think about that. If you're a diabetic patient and you develop an ulcer and then you finally get it healed, you've got a 40% chance to have a recurrence, not necessarily in that exact same space, but a recurrence, maybe, some other part of the foot or even contralateral. And now you're going to go through all of that care again, not only the hardship that it puts on the economic system, but the person that has to live through that, and then the person's family that has to live through that. It would save so much money if they would just say, all right, let's get on board with this. But you have organizations like the American Diabetic Association that they just want to shut this down because I don't know why. Is it because they're owned by high carb food industries like the the Idaho potato industry? It's like, they're all these 3-letter American Heart Association, American Diabetic Association. I'll probably get some flack for this, but I don't really care because they're captive to these big pharma, big ag companies, and that's writes them all the checks. But you would think from a payer standpoint that they would say, well, man, if somebody's had an ulcer, we should plug them into this kind of a program to prevent it, because we might spend another $15,000 or $20,000 to get them this care, but that's less than one wound easily. So, but they don't want to think about long-term savings. They just want to think about short-term, because I think they know that, and this isn't true for Medicare, I don't believe, but in the private world, where they run about 2 to 3 years before a person changes their coverage, so they don't have to worry about long-term effects.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen.
Hey Spelunkers, we're thrilled to kick off Season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of Season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk" on any of our Season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of Season 6 together.
You know, it's interesting you say that, Steve, because I think to your point, we talked about this at the nerve surgery meeting even too,
Yeah.
is that there are some very simplistic things. Example, easy one for podiatrists, diabetic shoes.
Right.
Diabetic shoe use in this country has gone down over 40% over the last 3 years. Why? Because the regulatory burdens are massive on the doctors, and they simply just say,
It's not worth it.
"I'm not going to do it. It's not worth
Right.
it."
Right.
Where clinically it's very worth it. It's been proven through the literature studies. Okay.
Right.
So what I at least perceive is that the people there are people in the value-based world who fully understand what you just said. Hey, if we do something here upstream and solve the problem now, we're going to save tons of money downstream. But the people who look at the bottom lines on the other side of the equation don't look at that. Well,
Right.
it costs too much money.
Right.
We're spending $3 million on this procedure.
Right.
But instead we're spending $30 million, way above, of course,
Right.
on the problems that come from it
Right.
because they're repetitive. Yeah.
Right. Well, I mean, there are so many examples of this where these carriers they actually incur more cost because they don't approve things up front. Okay, so let's say you have well, here's a great example, right? Let's say you have a patient with severe pes vagoplanis and they need to have a subtalar arthresis. Well, they don't want to pay for the arthresis because, and correct me, I don't think there's a code for that yet.
You are correct. There is no code for arthroresis.
Right. So there's no code for that. So this person that has this, basically you can think of it as a car that's out of alignment, and the person's going to keep driving it, wearing the tires out, shaking all the transmission, all of the things are affected by it. Whereas if they would have paid for that, then they might have saved themselves tremendous amounts of reconstructive surgery down the line, but that falls on deaf ears.
And you know what, Stephen? Still under CMS guidelines and Medicare guidelines, the terminology pes valgoplanus or flatfoot is a non-covered ICD-10 code. So
is that because there's no symptoms from it?
Well, good question.
you see what? Yeah.
Yes.
Yeah.
But there's a good example. And, I in my APMA leadership time, I can tell you, I mean, I made 16 trips to CMS and I left one time with something in my hand besides my rear end.
Yeah.
So, and there's a lot of really good and well-intending people. It's just that there doesn't seem to be a connection between, let's do this now. I mean, if you look at the risk side of things, where we're at, every diabetic theoretically should have an ABI, neurological exam, eye exam, right? Screening. Right. What does Medicare not pay for? Screening.
Right.
Because it's a system designed to pay for disease, not for prevention of disease.
Exactly.
And
the disease costs a hell of a lot more than the prevention.
Yes. Yes.
Yeah.
Yeah, just simplistic things like that. So, I mean, that's, I think that kind of leads to the point of where we're going is Medicare has made it pretty clear, could be a shot across the bow, but we'll see, that they want to do away with fee-for-service medicine by 2030.
And how would that work?
Well, that's a very good question. And right now, the idea is that everyone will become part of some sort of value-based system.
Okay.
So right now, the primary value-based and Medicare shared saving plan systems are Medicare Advantage plans.
Which are horrible. Which
don't have a great reputation. And for numbers of different reasons, we could probably have a whole separate podcast about.
Yeah.
But, part of it is reductions of coverages, lack of coverages, drive-by coding, which I could talk about later on too. But the idea is to move everyone toward a value-based type of system. Now, the good side of that is that if it actually functions the way it should, which I believe we're doing at Upperline, is when you recognize disease entities, which, by the way, Stephen, part of the reason that podiatry is so successful in this at this point, you and I have been required to recognize all those comorbidities that affect what happened with our patient simply to be paid for the things we do. Whereas an internist, a neurologist, a rheumatologist, whatever, without picking on a specialty, don't, right? You go to the internist, you go to the PCP, you have essential hypertension. Why are you here today? Well, also have this pain in my foot. Well, I don't take care of that. Go see a podiatrist.
Right.
Okay. Well, for us to be paid for that, though, we have to put down something associated with the flat foot, not the flat foot.
Right.
The neuropathy, the PAD, the obesity, the arterial sclerosis. We have to link all of those for us to even be paid for a lot of the things we do. That's what makes us appealing in the value-based world, because when those diseases are recognized early, Stephen, and then dealt with,
Right.
which has been one of the flaws of the Medicare Advantage plans, at least if you read pieces about what's going on, is the diseases are recognized by finding the codes that you and I actually find, but they're not managing the disease.
Right.
And so what we're doing at Upperline is, and not just a commercial for us, but I think we're doing this right, is that when one of our colleagues, as going to your earlier question, finds that, so they say a patient has obesity, they have PAD, they got a neurological deficit. Now we get them to either a colleague who's an expert in that area or a nurse practitioner so that it is dealt with on the spot. It's
Okay.
not simply just reported and ignored to
Right.
get more money from Medicare.
Right.
It's actually taken care of.
Got you.
Yeah.
So what are they going to do if they eliminate fee for service? Explain how this is going to, I mean, I can't imagine it because that's so radical. What's that going to look like?
Well, I think the ACO REACH program that we're in is a pilot that's due to sunset in 2026. We think it's going to be renewed. And I think if this works really well and they start adding all the other specialties in, which we're the first and only specialty ever in this program, by the way, which is really cool for us, we podiatric physicians, is I think they're going to have to expand that program dramatically and make it effective, or move everyone to a Medicare Advantage plan. Basically say your red, white, and blue card now, give you three choices. It's Humana, United, or Cigna, Aetna, whatever, and you've got to pick one. I mean, I don't know that for a fact, Stephen. That's just the only way I can see it working.
Well, why do they call it, Mike? Why do they call it a Medicare Advantage plan? Because to me, it seems like it's a Medicare disadvantaged plan. It has, it has, I mean, explain that to all the docs that are listening to this understand that anytime you see that, it's going to be less care and more regulation and more, hurdles to get the person the care that they needed. But explain to the non-physician part of the audience how these plans, I mean, they come on. You see the commercial on every night while you're watching the news about how great this thing is, how it pays for everything from, stopping down there to pick up a chicken sandwich for you on your way. I mean, it's ludicrous that they advertise like this because it's just the opposite.
And the concept of it, Stephen, is good, right? The concept is good.
Okay.
I think the construct of it is good. Its design is to. So let me back up a little bit. So I think it was during the George W. Bush era where he really wanted to privatize Medicare. Okay. And part of that is to move the expenses out of the government and give private entities the opportunity to manage the health care instead. Fine. So Medicare dollars are used to pay Medicare Advantage plans for the management of a Medicare aged recipient. How is that done? I don't know all the details, but part of the way it's done is by the capturing of coding, ICD-10 code, their diagnostic codes. They're given a RAF score, which is a relative adjustment factor, or a risk adjustment factor, rather. So the sicker a person is, the more money that plan gets to take care of them, which sort of makes sense. So if if Dr. Steve Barrett goes there and he takes no medications and he's pretty healthy, there's going to be a certain amount paid to that plan per month to manage your care. If you get sicker and there's a problem, that falls on them. If they're given more money and they save that money by taking care of you well, they make money, right? They get a bonus,
Right.
and not even a bonus, but they get more profit.
Okay.
So it's really the privatization of Medicare. And
All right.
so the idea is the idea and the construct was to be value-based, is that, hey, let's find diseases early, let's recognize those, and let's take care of them. The flaws that people are seeing, at least based in the lawsuit things I read about, is that they're finding the codes right or wrong, but they're not managing the disease.
So I'm still confused about how, if it's not going to be fee for service, how are they going to determine what to pay the provider?
Well, that will then become a privatized scale. Now, would Medicare tell them what that is? Theoretically, all Medicare Advantage plans are supposed to follow the Medicare guidelines and laws completely for coverages. Theoretically.
Okay.
But they have the ability to adjust the payments.
Okay.
Okay, so hence we can see why we get paid differently.
Right.
than we
But
do.
but let me ask you this. If it's going to go to a non-fee for service, then the patient comes to see the doc.
Yep.
What do? Do they send in a code with a CPT code with a diagnosis code, or
Yep. Just
still
like
the same thing?
Same thing.
Okay.
Same thing. The difference is that plan now gets to set that rate.
Which it's they're already doing that.
Right. Medicare has its rate, right? I mean, at least
Yeah.
Medicare, with all its flaws, is fairly black and white. Here's
Right.
the approved amount. Here's what you can co-pay bill. Here's what you can't, right?
Right.
The MA plans have a lot more latitude in what they do with that stuff. That's been the bane of, I would say, of our provider's existence. It's privatized. I mean, it's private Medicare is really what it is. It's commercial insurance managing your Medicare money.
And it's another layer of bureaucracy.
That's another layer of bureaucracy, yes. And the construct was designed to be doing the right thing. It just doesn't seem to work that way.
And now, a message from our sponsor. The power of ketones, your body's alternative fuel. The folks at Approved Medical Solutions have done it again. That's right, with their new Clean Ketones supplement. Imagine your body as a hybrid car capable of running on 2 different fuel sources. While glucose is your body's regular gasoline, ketones are like switching to an efficient, clean-burning alternative fuel. I would say rocket fuel. When your body produces ketones, whether through fasting, low-carb dieting, or intense exercise, something remarkable happens. These molecular powerhouses cross the blood-brain barrier, providing crystal-clear mental energy that many describe as enhanced focus and clarity. But ketones aren't just brain fuel. They're efficient energy sources for your heart, muscles, and other vital organs. Think of them as premium-grade fuel that produces less metabolic waste than glucose processing. Research suggests ketones may offer additional benefits: reduced inflammation, improved metabolic health, and even potential neuroprotective properties. They're particularly interesting for athletes seeking sustained energy and anyone looking to optimize their cognitive performance. The best part? Your body is naturally designed to produce and use ketones. It's not about completely replacing glucose, it's about metabolic flexibility, giving your body the ability to thrive on both fuel sources. Whether you're interested in mental clarity, athletic performance, or overall health, understanding and harnessing the power of ketones might be your key to unlocking new levels of well-being. Approved Medical Solutions Clean Ketone Formula contains nature-identical ketones. These ketones provide the same fuel as those produced through a keto diet. Approved Medical Solutions Ketone Formula does not contain sugar, caffeine, or 1,3-butane-diol, and they are not ketone salts. I've been using them routinely now and notice a minimum of a 10% increase in exercise performance. By diving deep into cutting-edge research and real-world applications with leading scientists and practitioners, The Pot of Inquiry illuminates the science-backed path to enhancing your mind and body's potential. You can find us on all platforms, including Spotify and Apple Podcasts. Please join us.
Well, I think the law of unintended consequences comes into play quite a bit too. But to me, Mike, I don't want to be negative, but I've never seen anything positive in my 38 plus years of playing in this arena, where they come out with this new invention or this new idea, and it's going to be, great example is EMRs. They were supposed to save everybody all of this anguish and expediency and getting a record from this hospital to this clinic and all this other stuff. And we know how that turned out. And it was mandated. We didn't have a choice, So how is it that by turning over these folks to these Medicare Advantage plans, privatized or not privatized, it's another layer of bureaucracy. It can't increase reimbursement. It's going to, if anything, greatly decrease reimbursement.
I would tend to agree with you. Now, the benefit of the ACO side of things is that doctors can be compliantly bonused for helping an ACO find the sicker patients. So the model of an ACO, which is similar to a Medicare Advantage plan. The difference is Medicare Advantage. Remember, we used to get risk checks, Stephen? Remember years ago, if you saved, maybe you were part of this. If you saved a plan money, you got money. You were rewarded for that, which was good because it gave you an incentive to be a good evidence-based provider with good outcomes. Well, I don't remember the last time I ever saw one of those checks, quite frankly, from any of those plans.
No.
In an ACO model, if you manage it properly, if the doctors are finding those sick patients, you could actually bonus the doctor for finding those people and providing that care before it gets downstream to a problem. I'm hoping that model will be somewhat of an incentive for us to be better about outcomes and protocols, as opposed to just, like you mentioned earlier, the reimbursement-based system.
Right.
Am I positive it's going to work? No.
Right.
Do I always think CMS can, they like to shoot across the bow,
right,
and see what happens. So we'll see if it really comes to fruition.
Well, there's going to probably be tremendous amounts of hurdles to the provider. Anytime you switch to a different system, there's all of these additional things that the providers have to do, hoops that they have to jump through, and you just wonder. You just really wonder. I just, based on their past experience, I can't see anything positive coming from it. And I'm an optimist. In life, I'm a very optimistic person, but I see no optimism in this whatsoever.
Well, you know what, Steve? We've had so many regulatory burdens and hurdles that it seems like every time we find, this sounds bad to put it this way, a way around a hurdle, there's another one that's built.
Right. No.
And most of us are willing to figure out how to work with the hurdles, but every time we do, a good example were the lawsuits that we had against payers many years ago. Mm-hmm. And AMA was successful, APMA was successful, and then the second version came through, we weren't as successful, and then 2 years later, everything reverted back to doing what they were doing. And so, I think I'm optimistic too, but I'm definitely pessimistic about the system that way, because we've unfortunately constantly run up against those roadblocks. And I am a little concerned about, very concerned about how are they going to pull this off? That's a massive change. Massive.
Right. Well, I think that it will be done in the typical fashion that they've done things the last 5 decades. And let's see, Medicare's been around since what, about 1970 something, in that neighborhood?
Yeah, I'm trying to think. I think
73 or something. I don't know.
Let's see. Yeah, because FDR invented it. I can't remember which president got us in there, but it was probably, maybe even in the 50s, something like that. But it's been around a while. Yes.
Yeah. Well, that's interesting. So basically, this is supposed to happen by when? 2030?
2030. That's the plan.
Okay.
Yeah.
That's not that far away.
No, it's not. It's going to be honest. You and I will both be retired and doing this kind of stuff.
I
But
hope.
yeah, that's true.
Yeah. Yeah.
But yeah, I think, what's gotten me excited about the ACO side of things was I think we're doing it right. And I'm biased, of course, but I think we're doing
Right.
it right because we're providing the care, we're bonusing doctors for helping find sick patients, and we're managing those sick patients. That's the construct of where MA plans, I think, were really designed. They just haven't gone there. Can they go there? I don't
Yeah.
know. I'm pretty skeptical myself that way too. I'm expecting that this ACO REACH program is going to explode as opposed to implode, um, because they're going to have a place to put all these people, Steve.
Yeah.
And
Yeah.
the good news about it is that in the ACO program that we have too, that they don't have to change their doctors. They still have their regular PCPs and specialists, and they don't have to change any of that stuff. And all the ancillary care that we provide, by the way, is included. There's no co-payments for it. So patients get
Okay.
these extra services. Yeah, we don't charge them. I mean, we send bills to Medicare because we have to do that, right? It's
Right.
still a Medicare program. We have to follow Medicare guidelines. But to the patient side of it is that we don't have to, they don't get dinged for it.
Interesting.
Uh, and so, I mean, that's the way the system was designed to work.
Right.
And I think to your earlier point, we're really trying. I mean, I spent about 9 months building protocols, trying to use as much EBM or evidence-based medicine as possible so that people can be fairly reimbursed, whatever that means,
Right.
fairly reimbursed, but still and have good outcomes, but using evidence-based care, not simply doing things to do them and get paid.
Yeah, I think well, first of all, I think evidence-based medicine is a bit of it's a, it's a disguise for insurance companies that we don't want to pay for it. Because if you look at all of the things that we do, how much of it is truly evidence-based? Not that significant. I would bet 10, 15% maybe. I mean, and their evidence-based is all BS too, because if you send them a study of 1,000 patients, they'll come back and they'll say that's not enough. We need 10,000 patients. And so they'll play that game. So they hide behind, I think insurance companies have been hiding behind evidence-based medicine as a term, as a philosophy since and I don't remember when the term came out, but it wasn't that long ago. It was it was kind of like one of those Orwellian things. It's like, okay, we'll put a cool name on it, and that'll let us not have to pay for things.
Well, I'll give you a great example of what's going on right now. It's changing gears a little bit, but biologics, skin grafts,
Right.
cellular tissue products, whatever you want to call them, they keep changing terminology.
Right.
CMS last April came out with a reduction of 230 CTPs down to 55.
Okay.
4 applications in a lifetime.
All
4.
right. Okay.
All right. So what did they use? They displayed all of these so-called RCTs and EBMs to say why they shouldn't be paying for these products. Now, there's a glut of them out there. There's probably some validity to some of this, of course. But I think they had over 80 lawsuits in the first week over this. So they pulled the policy back. Now they just 2 weeks ago came back out with a new one. This time there's only 17 covered products on there. And
Okay.
what did they do? They did exactly what you just said. They started listing all of the most, in my opinion, most negative RCTs they could find as to why they didn't want to cover product.
Mm-hmm. Right.
And so, and many of them from our own colleagues, by the way, but they, the ones that maybe truly were evidence-based, I'm not sure I saw too many of those. But they're using those as their reasoning for not covering some of these products. I'm
Right.
not an expert in all these products, so I'm not supporting or denigrating any of them. But
Right.
they took out 200 and some products that, as of next February, are theoretically going away.
Mm.
Um,
Interesting.
so to your point, they're using our own science, if you will, against us.
Right.
And there are places for that, of course, right?
Right.
So
Right.
to your earlier point earlier about arthroresis, I mean, Mike Graham, to his credit, was trying like hell to get
Right.
things moving that way, but never could get enough good science behind it to say we should make this work.
And I'd have to defend Mike on that because I think Mike actually did some really great science. And I would say it comes down to no matter how good it is, if you're hiding behind EBM as a fence to keep you from paying out premiums that you've collected, you're going to make that, you're just going to keep moving the goalpost. And I think that's what, I mean, first of all, it's an empirical thing. All right. It's not like it's an unknown new drug that there's never been any experience with. I mean, this technique, this surgery has been around since early 70s, or actually earlier than that, if you go back to Green Grice in the 50s. So so it's been around for a long time.
I did a ton of those as a resident. Yeah.
Right.
Yep.
So how much is enough, guys? I mean, and I think that's where Mike Graham's work falls into, because he's got some really powerful, good work.
Well,
but they just don't.
I will tell you, Steve, part of it too has come down to CPT won't give them a code because the orthopedic community won't sign on to the arthroresis.
Yeah, that's probably relative.
So maybe I'll even use that as more of a being bluntly transparent here.
Yeah.
So APMA has gone about 3 times to CPT for a code and sort of given up now because the orthopedic community won't sign on to it.
Right. Yeah, there's a lot of different agendas in this whole world that
yes.
are, that once you peel back the curtains a little bit, you go, wow, I didn't know that this was the case of that,
And it's interesting. So I'll go back to value-based healthcare for a minute again to your agenda point made me think of this. So sorry, we're friends.
No.
We can bounce all over.
Right.
If we were sitting drinking some of that great Savant wine, we'd be doing the same thing.
There you go.
Shameless plug. Anyway,
and I didn't ask you for that. Just
you did not ask me for that, but it's some of the best wine in the world. Anyway,
appreciate that.
Yeah, some
I'm
of the
drinking it right
now. I think part of why some of this hasn't worked so far is, to your point, there's other agendas. The people who understand how good outcomes can come from volume of visits, application of services, uses of product, like you just said, doing a simple nerve decompression that can change the entire quality of life for a patient.
Right.
And the clinical outcomes down the road, because they've ignored the real evidence-based study like Scott did, right?
Right.
As opposed to using one from somebody who just didn't like that procedure, doesn't like Lee Dellen or something like that, right?
Right.
And so there's those agendas behind there. And then to your other point too, there are certainly the manufacturers and the pharma and the industry who gets behind it, and some of them very well intending, but as soon as they get involved, things get kiboshed. So, and I think the hospitals have struggled, my opinion again, with the value-based side of things, because I don't think they can get out of their own fee-for-service mindset.
So that brings up a question I have to ask. And I hear, first of all, the hospital lobby is a huge lobby. And they have been, in many ways, in my opinion, which is relatively uninformed, not a help to overall healthcare. Because some of the things, for example, in the state of Georgia, we know it's so hard to get a surgery center because of certificate of need. And that's because of the hospital lobby.
We could not even have them in Massachusetts because the hospitals own the market.
Right. And so what kind of a marketplace is that? That's not a market. That's not a free market, because surgery centers can do it better, faster, less money, less infection, more convenience to the surgeon. I mean, it's not even comparable as far as ease of use and for both the physician and the patient. But you have these. So my question is, hospitals seem to be just billing like crazy now, and yet they still say that they're not making any money. Tell me what you think.
Well, it's interesting. If you're not making any money, how can you build a mile-long facility along a major highway, by every surgery center in your path, and by every physician practice in your path?
That's what I mean.
That's my take. And I see, for example, you and I were around all sorts of those. We've been around them all our lives. But I was in Southern Massachusetts. So there's two major systems there. One, which by the way has recently failed, Stewart Healthcare, which you've probably read about,
Hmm.
is now being bought up by all these other hospital entities.
Right.
And then there's South Coast, who's down there, who owns the whole southern shore now. And then there's Partners, who owns the whole eastern shore. So how do they do that? I mean, I'm sure some of it's debt and et cetera, and I'm not a financial wizard or expert here, but I've often wondered the same thing too. It just seems to me that the behemoths just become more behemoth,
Right.
and those small community facilities that probably are cheaper go under. And to
Right.
your point, in this value-based world that we're going to, outpatient surgical centers have to be the way to go
You
because the
would think.
facility fees are less, the overall costs are much less. It's 5,000 to do. I don't know these numbers exactly, Steve, but
Right.
it's
Right.
5,000 to do a bunionectomy and a couple of hammer toes instead of 32,500
Right.
to do the same thing in a hospital.
Right.
So hospitals have their place, their necessity. I mean, we all know we get that too.
Yeah,
But
but I mean, for acute care trauma, there's no
yes,
other place in the world that you want to go.
yes,
You know, there's nobody that, I mean, our system is best in that,
but
but chronic care, we're probably last because we could care less about preventing disease and it's all about treating disease.
yes, and think about it, Steve. How many of our patients, not because, how many, not even just our patients, how many patients go to the emergency room for an ingrown toenail? I mean, they could call our
Yeah.
office and get in the next day.
Yeah. And how many go because they go there and they complain of low back pain and they get their MRI right away versus having to wait 3 months or
Yes.
3 weeks or whatever it is out in the public sector. So yeah, no, it's a lot of misuse and
Well,
everything.
and that's a whole other topic. I mean, the paucity of physicians. I mean, podiatry schools are down 40% plus right now.
Right.
I'm not even sure. Allopathic schools, I think, are down. I
Quite
think
a bit.
osteopathics have been doing okay.
Right.
Uh, but PA and NP programs have been exploding.
Right. Well, I mean, Mike, look at the cost to get through the educational process now, not
Yes.
just the tuition, but the poor kids have to live, they have to eat, they have to, have something to drive. Then they go through residency and some of them go on to fellowship, which they're not making much money. And then when you get into the situation of, well, you're finally getting out there and practice, well, you've got a huge debt load that
Yes.
it's a pretty big load to carry. And
It's like a second mortgage,
yeah, or
if you
more.
can even get a mortgage.
Right,
Yeah.
right. And so I think people are waking up to this, and the other thing is that the physician burnout is so high right now because of all of the regulations, how you spend more time treating the computer than you do treating the patient. So all of these factors are going against it, and so the system is contracting from a provider standpoint very rapidly. And I think this is going to be a problem, maybe not in our lifetimes, but in our children's lifetime. How are you going to find somebody to take care of you?
Well, it's funny because my wife and I talk about this now already at this point in life. I'm fearful about who's going to take care of me. I mean, it used to be I could pick up the phone and call my buddy
Right,
and, give me a hand, but they're either all dead or retired now, sadly.
right,
But, it's like, who's going to take care of me? I mean, when you got a PCP who's already maxed out, or you got a specialist who's maxed out, or you got a facility who can't, like you said, can't do an MRI for 3 months. Um,
right.
it took my wife 9 months to be able to get an MRI properly done for her low back problem. So there you
Yeah,
go.
right. No, it's unbelievable. Well, Mike, it's always fascinating for me to hang out with you because you have such a great, vast knowledge of things that I have very little understanding of. So it's all
No, you have a whole lot more. You have a whole lot more than the average doc. Trust me.
maybe that's kind, but it's such a, I mean, it's almost a subspecialty in itself, what you're doing for Upperline. I mean, you're looking at things, you're doing very deep dives on these ACOs and all of this other stuff. And the poor provider out there, he's trying to do his deal or her deal. And so you're kind of like a specialist within this specialty to figure out, well, how can I get these people to be able to provide care and what you're doing with the big group, making their lives better. And so my hat's off to you. I know that you've been through a lot of stuff when it comes to, trying to weed through these regulations and everything, but If there weren't people like you doing that, everybody would be much worse. So thanks so much
Well,
for
I
that.
appreciate that, Steve. You know what? Something that I'll retire a happy guy if people will just finally realize what we podiatric physicians and surgeons really do offer every day.
Yeah,
We don't just cut toenails. I mean, we do so much more, and we just want to be part of that general community. And if people can just look at us and realize that,
right.
I will retire happy. And if our patients come out of that better, and like you said, I mean, we're going to spend $1 trillion on diabetic limb care by 2035. $1 trillion if we don't change the system.
Right.
So
No, it needs to be changed.
yeah,
So,
but I appreciate your kind words. It's very nice.
well, thanks so much, man. Be good. Let's chat soon.
Pleasure, brother. Be good.
All right, be
Everyone,
good.
have a great day and happy holidays.
As you know, I'm passionate about learning new ways to address health concerns. Moreover, before I recommend any treatment or supplement, I always try it on myself. Today, I want to share my experience with Troche. I have investigated other phytocannabinoid formulas and found that, in general, they were not consistent or reliable in their results. What impressed me about the Troche delivery technology is that each rapid-release tab is engineered to provide fast-acting, long-lasting, reliable delivery of phytocannabinoids to support your health and well-being. Many physicians understand the importance of using phytocannabinoids for physical discomfort, sleep issues, and mood. But if the formula is not reliable, most patients will give up, never experiencing the real benefits. I put this to the test on myself and actually tracked my progress. This graph shows my results for reducing stress. Troche is so serious about how well their product works, they partnered with People Science to provide the Troche Tracker health assessment application that lets you monitor your progress and works with you to accomplish your wellness goals. If you are a patient, click the link below and the patient button to register for Troche Tracker. Assess your baseline health metrics and receive a free Troche sample in addition to getting preferred patient pricing on all products. If you are a clinician interested in adding Troche to your practice, click the link below and then the clinician button to register for a wholesale affiliate account or go to the link above. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.